will hand over the session to you, sir.
Okay.
So it's 3, 2, 1. Over to you, sir.
Good evening. At the outset, I thank for this opportunity. So today we are going to discuss about management of hypertension and heart. 30 minutes. May 17th is the May 17th is the World Hypertension Day. It is initiated by World Hypertension League. So the hypertension affects, it's a systemic disease which affects all organs of body. So this disease starts from our heart. It also affects our brain in the form of stroke, heart in the form of LVH, hypertensive heart disease, heart failure, and MI. So kidneys in the form of hypertensive nephropathy and also hypertensive retinopathy. Among the diseases, the macrovascular disease being heart and brain are affected with macrovascular diseases. When hypertension affects microvascular disease, the main organs involved are kidney and eyes. The theme of 2016, know your numbers. How much the target or how much the BP level we should diagnose hypertension. After approximately 4 in 10 adults have raised blood pressure, which often goes undiagnosed. So 4 out of 10 undiagnosed. Hypertension is the leading risk factor for disease burden worldwide. This is the number one cause of disease burden developed in countries and cause of disease burden in developing countries. And number one cause of stroke and heart failure and second cause of heart attack. Next to diabetes. What are the diseases that can leads to mortality? This is a non-communicable disease which can lead to number of deaths, more number of deaths next to diabetes. So cardiovascular disease is still leading cause of mortality. So hypertension can produce hypertensive heart disease, heart failure, and myocardial infarction, cardiomyopathy, and also stroke. These all falls in the spectrum of cardiovascular diseases. So American Family Physicians Association of American Family Physicians, that is AAFP, has shown that population above 18 without known hypertension, this patient should be recommended for screening. Whenever the patient's age is 18, above 18, when they are arriving at college, they have to be screened for blood pressure measurement. So at that time, you can screen them. At the age of 18, all adults should be screened. Adults more than 40 years, increased risk of blood pressure should be screened annually. Aged between 18 and 39 with normal BP who do not have other risk factors should be screened every 3 to 5 years. So people at screen should be screened, the people at risk should be screened annually. People not at risk with normal BPs should be screened every 3 to 5 years. What are the symptoms of organ damage in hypertension? As I said earlier, brain and eyes can produce headache, vertigo, impaired vision, giddiness, transient ischemic attack, sensory or motor deficits, stroke, carotid revascularization. Can affect in the heart in the form of shortness of breath, chest pain, and ankle edema, myocardial infarction, LV dysfunction, revascularization, syncope, history of palpitation and arrhythmia, especially atrial fibrillation and hypertensive heart diseases. And the kidney can produce thirst, polyuria, nocturia, hematuria. Peripheral arteries can produce gangrene or occlusion, can lead to cold extremities, symptom called claudication, pain-free walking distance, and peripheral revascularization. History of snoring, chronic lung disease, sleep apnea, cognitive dysfunction. These are the some manifestations. Which signs suggest organ damage in hypertension? Brain, motor, sensory deficits, retina, fundoscopy abnormalities in the form of hypertensive retinopathy, heart, grade 3, or, sorry, third or fourth option, LVS3 or LVS4, heart rate tachycardia, cardiac murmurs, arrhythmias, down and out is shift of apical impulse, pulmonary crepitations, and peripheral edema, ankle edema. Peripheral arteries, absence of pulse or reduction of pulse, asymmetry in pulse, and cold and clammy extremities, skin necrosis. Carotid bruit is one of the symptoms the patient can have hypertension. Looking at the laboratory findings, hemoglobin, fasting glucose, lipid profile, fasting TGL, potassium and sodium should be measured because most of the drugs acts on sodium and potassium. And serum uric acid, creatine should be measured at the beginning of diagnosis of hypertension. Urine analysis to rule out albuminuria and the 12 lead ECG. HbA1c, proteinuria, ambulatory BP recording for 24 hours, and echocardiogram, Holter monitoring, carotid ultrasound, peripheral artery disease, abdominal ultrasound, renal artery Doppler, pulse velocity, ABA index, and fundoscopy. So, cardiac complications, as I said earlier, LVH, heart failure, stable angina, unstable angina, myocardial infarction, cardiac arrhythmia. What are the management strategies in treatment of hypertension? So, coming to management strategies, goal of therapy, effect of BP in order to prevent, reverse, or delay the progression of complications. How to manage the BP effectively and reduce the complications. What are the benefits of achieving BP goals? When BP is reduced from its high level to target level, or when it reaches goal, there is a 20 to 25% reduction in myocardial infarction, 40% reduction in stroke, 50% reduction in heart failure, and 50% reduction in renal failure. So, what are the benefits we will get with the BP lowering drugs and its outcome? So, for every 1,000 patients treated for 5 years, systolic BP of 10 and diastolic BP of 5 is lowered. So there will be 17 strokes are reduced and 28 cardiovascular events and 7 cardiovascular deaths are reduced. So coming to management of BP by lifestyle, reduce your weight, go for regular exercise, DASH diet, which is rich in protein, fruits, and vegetables, and contains lot of fibers, less fat, less saturated fat, and sodium should be reduced to 2.4 grams per day. And further reduction of sodium is desirable when BP is needed to be reduced more, and reduce intake to less than 1 gram per day if BP level is not tolerated. Physical activity, regular aerobic exercise. So there should be only cardiac activity, cardio exercises that leads to only aerobic thing, not your isometric exercise should be discouraged. Weightlifting can tone the muscles, not to build the muscle. Moderation of alcohol consumption. Now the advice is to avoid alcohol. So previously we used to moderate. What are the first line choices available for management? Coming to diabetic, this is a definitive indication is heart failure, elderly patient, and systolic hypertension. So when the diuretic and ACE inhibitors are combined, there is a great reduction in stroke incidence in ALHA trial. So we have to use diuretic as a first line in elderly patients, systolic hypertension, isolated systolic hypertension, and heart failure patients. Possible indication diabetes and definitely indication gout, contraindication, gout, diuretic should be avoided. Related contraindication, dyslipidemia. Beta blockers, when there is ME, post-ME, angina, tachyarrhythmia, heart failure, hyperthyroidism, anxiety, beta blockers should be preferred. Young individual, beta blockers should be avoided. Pregnancy, possible indication, diabetes and pregnancy, heart block, and young individuals, beta blocker can be avoided. Relative contraindications, dyslipidemia, physically active, peripheral vascular diseases, and asthma. Calcium channel blocker is metabolic syndrome, ideal indication because it doesn't interfere with the lipid level and HbA1c levels. angina, elderly, systolic, isolated systolic hypertension, and diabetes because it's neutral on HbA1c and possible indications being peripheral vascular disease, vasodilator, and CVA is another indication. Definitely contraindication, heart block, especially dietopide in calcium channel can be used in heart block when there is a variator alkaloids like verapamil or DDSM should be avoided in heart blocks. Congestive heart failure is a relative contraindication because it produces vasodilatation, thereby increasing edema. AC inhibitor, metabolic syndrome is the ideal drug. Heart failure, compelling indication, left ventricular dysfunction post MA, significant proteinuria, and diabetes. So CVA is a possible indication. There's a contraindication, pregnancy, lactation, bilateral renal stenosis, possible contraindication, basic creatinine. Angiotensin 2 receptor, same as previous. Here, this risk reduction, heart failure reduction by 10% and major cardiovascular risks and stroke by 9%, stroke reduction by 9%, prevents 9 strokes, 7 heart failure, and 20 major cardiovascular events within 5 years for every 1,000 patients treated. Indian hypertension guidelines 2. Salient features of beta blockers, inexpensive, relatively well tolerated, preferred in stable and unstable angina, post MA patients, heart failure, young hypertensives, intolerant AC inhibitors, ARBs, women of childbearing potential, and cardio-selective beta blockers preferred over non-selective ones. A large meta-analysis by Law et al. Showed that initiation of beta blocker equally effective as major class of antihypertensive therapy in preventing coronary outcomes. Highly effective in preventing CV events in patients a recent MA and those heart failure. BP lowering treatment trial is collaboration. Said that similar incidence is noted with beta blocker. Alpha as we already seen, non-inferior beta blocker clothed combination in patients with strokes when compared to other drug classes. So CCP, calcium blocker, camelot study, risk reductions demonstrated. CV events are reduced. Thiazide diuretic, it's a thiazide and thiazide-like diuretic chlorothalidone and thindopamide are potent reducers of BP. A major impact in stroke and heart failure also reduce mortality. What are the latest guideline recommendations? So hypertension with the CAD 2015 ACC scientific statement showed that diuretics is the first drug of choice and chlorothalidone is preferred over uh, thiazide diuretics. This is chlorothalidone is thiazide-like diuretics. Thiazide diuretic is hydrochlorothiazide. JNC 8 2014 criteria. So in the general non-black population, including those diabetes, initial antihypertensive including those in antihypertensive treatment should include thiazide type diuretic, calcium channel blocker, angiotensin converting enzymes, and inhibitor, and the angiotensin receptor blocker. In general population, including those with diabetes, initial antihypertensive treatment should include thiazide diuretic or CCP. So goal BP should be less than 140 by 90. It is published by James P.A. et al. In Journal of American Medical Association in 2014 February. So what is European Society Hypertension Guidelines, CSH 2013 guidelines? So in hypertensive patients with CHD, SBP goal of less than 140 or 140 should be considered. It's a class 2. Level of recommendation is B. So in hypertensive patients with recent MA, beta blockers are recommended. In case of others, CHD, all antihypertensives can be used, but beta blockers and calcium channel blockers are to be preferred symptomatic patients in angina. Diuretics, beta blockers, AC inhibitors, ARBs, and mineral MRA are recommended in patients with heart failure or severe LV dysfunction to reduce mortality and hospitalization. This is class 1. Level of recommendation is A. Indication is class 1. AC inhibitor Angiotensin receptor blocker, beta blocker, MRA should be considered as an antihypertensive of choice in patients with recurrent atrial fibrillation or in patients with the risk for AF. So it's a class 2A indication. So atrial fibrillation, beta blockers helps in reducing the heart rate. So thereby reducing BP and also the heart rate. So beta blockers are the ideal choice of drugs in atrial fibrillation. When there is a more fibrosis, we need compelling drug as spironolactone or eplerenone. It reduces fibrosis. It comes under MRA classification, mineralocorticoid receptor antagonist. And AC inhibitor and ARB plays vital role in patients with atrial fibrillation, especially when left atrium is dilated. It is used to reduce fibrosis. It is also can be used in patients with hypertension and atrial fibrillation. And it is recommended that all patients with LVH should receive antihypertensive agent. In LVH, ideal drug should be AC inhibitor or ARB. If the patient is hypertensive and without any drugs, if there is isolated systolic hypertension, we should use calcium channel blocker and diuretic as the first choice. You can add on AC inhibitor or ARB along with these agents. Beta blocker should be preferred in patients with angina, post-MI, coronary artery disease, heart failure, tachycardia, hyperthyroidism, anxiety. These are the conditions we have to prefer beta blocker in these patients. Beta blocker should be avoided in young males, patients who are feeling fatigue, who are intolerant, peripheral artery disease, and beta blocker should be avoided in patients with heart block and in patients with LVH, initiation of treatment with the one of agents that have shown a great ability to regress LVH should be considered. That is AC inhibitor or ARB should be considered. It's a class 2A recommendation, 2A indication. Level of recommendation is level B. So looking at the final classification, there are five important classes of drugs coming from diuretic, calcium channel blockers, RAS inhibitors, beta blockers, and MRAs. So looking at all these drugs, hypertension, mainly if the patient is having moderate or severe hypertension, the automatic choice will be long-acting diuretic like indapamide or chlorothalidone along with calcium channel blockers. AC inhibitor ARB should be considered in all patients unless there is no contraindication because it is metabolically neutral and is not acting on the conduction system. So AC inhibitor ARB are the drugs which can play in all levels of hypertension. MRA and beta blocker should be considered in patients with heart failure. Beta blocker, as I said, large number of indications for beta blocker. Angiotensin converting AC inhibitor and ARB is especially helpful in patients with proteinuria to prevent renal complications also. AC inhibitor in aldosterone along with diuretic are shown to reduce CVA. So thank you for patient hearing. Any doubt we can address.
Thank you so much, sir, for this wonderful presentation. As of now, there is no question, but can we wait for a 1 minute if participants have any
Yes,
questions?
ma'am. Sure, sure, ma'am.
Okay, I'm requesting our dear delegates if they have any questions or queries, they can put it in a chat box. I think your presentation has covered up all the queries of the participants. So, with your permission, shall we close this meeting, sir?
Thank you, madam. Thanks a lot. I thank all the participants for patient hearing. Thank you.
Yeah, once again, thank you so much, sir, for your clinical insights and dear participants for joining. So, from here, I